Mike, you're going to tell us about what happened when you looked at acute kidney injury and its impact on mortality and cost in one of your centres.
Yeah, so I worked in Virginia before going to Penn, and I was brought in basically as someone as medical director of the perioperative and surgical sector to put ERAS in and reset the surgical space. And we went vertically with all the ERAS elements across all the specialties, and then horizontally. And the two key things you've got to do horizontally on your pathway is basically opioid-sparing analgesia, functional analgesia, and goal-directed hemodynamic therapy, according to what type of surgery it is, laparoscopic open or laparoscopic to open conversion. But to get buy-in with your surgeons, you've got to show that you're doing good. So in order to introduce goal-directed hemodynamic therapy, we focused a lot on SSI and AKI. Those are good measures to drive quality improvement, because those are both affected by fixing volume and pressure. We did a huge amount of work here, and I'll give Brenton French and Pranav Shah and the team a huge shout out for this. We looked at 60,000 patients, consecutive patients, took out all those who are non-cardiac having major abdominal surgery, and it came to 6,729 patients, so 6,700 patients. And we looked at we mapped costs, but also we looked at mortality. Now, at this point in the literature, everyone knew that stage 2, stage 3 AKI in cardiac was related to poor outcomes. But no one had really looked at stage 1 AKI. And I'm sure you all know that you sort of round in the morning, don't you, with the surgeons? It's just a little bump in the AKI to get a stage 1 of 0.3. But on the right here, you can see that these are the survival curves at 1 year. So my team actually looked at the Social Security data set and phoned everyone of 6,700 patients. So this was a really big study to get this data. And can you see that the green line is no AKI, the blue line stage 1 AKI, pink stage 2, and then stage 3. So this is 1 year mortality at the end on the right. And just to delve into the figures here, you can see that, first of all, stage 1 AKI still gives you additional days in hospital, 1.9 additional days, stage 2, 2.6. So the patients are sitting in bed, they don't look any different, except if you've got hypersonic hearing, you can hear the kidneys screaming because they've been injured. But the inpatient mortality had also gone up. So you can see stage 1, 5.5, stage 2, 10.9, stage 3, 13.9. So what we're seeing is that it's not just an inconvenience that these patients are staying in longer. It's having a long-term 1 year mortality effect. And then when we looked at costs, we used the modelling cost that we use for CMS, because this often, VCU was involved in modelling CMS episode plannable payments. So this is high-level cost calculations. You can see just for stage 1 AKI, you've got $4,391 per case extra cost, $6,700. Now, when you look at nationally, we've got an AKI rate of 8 to 15%. If you think if 1 in 8 patients are getting an AKI, you can divide the average of that, say $5,000 between 8. So we could spend $600 on every patient just in anything we wanted to do, and we'd still save money and we'd stop the patients getting harm, because that's the actual health economics. I think
we'll come back to it, but you did intervene and make a big difference.
Yes, we did. So we'll come back and show how we changed this. Yeah.
Brilliant. Thanks. Well, what's up next?
Thanks.
Bernd, endotypes. So we're all in agreement that there's a causation and association. Mike's implied the fact that you can do something different about it. You've told us about reducing the incidence of hypotension. What's the endotype story?
Yeah, well, we agreed that we should avoid hypotension, and we also saw that kind of a reflex now is that we give a vasopressor to a patient who is hypotensive. And perhaps, well, it's our fault because we pushed very heavily during the last years telling people to avoid hypotension. And we need to admit it's an easy way to at least correct the hypotensive number on the screen. So if we give a vasopressor, then blood pressure will increase instantly. And so I don't think that we should blame ourselves or the colleagues, because it's an obvious way to react to hypotension. But I think we all also acknowledge that cardiovascular dynamics are complex and that hypotension is not kind of a uniform disease. It's a symptom of hemodynamic instability, and there can be very, very different root causes. And we wanted to kind of provide objective data on this, relatively obvious assumption that there are different causes, and we looked at patients having major abdominal surgery, and all of those patients had advanced hemodynamic monitoring. So we identified hypotensive episodes, meaning that episodes where the patient was hypotensive, and we looked at the advanced hemodynamic variables during those episodes. So we looked at heart rate, stroke volume index, cardiac index, systemic vascular resistance, and pulse pressure variation. And this was a relatively small data set, but we now repeated this in numerous other substantially bigger data sets. So here we used an artificial intelligence algorithm, to more specifically machine learning, hierarchical clustering, and we kind of asked the algorithm to identify different subtypes of hypotension, or we call it the endotypes, so different clusters of hypotension. And indeed, the algorithm was able to differentiate and to identify basically 4 distinct different endotypes, and those, not surprisingly, are hypovolemia, vasodilation, bradycardia, and what we call myocardial depression. And it's kind of using machine learning to demonstrate something that physiologic rationale already told us. But we were pleased that an objective statistical method like this also is able to identify those different endotypes. And if we consider those endotypes during hemodynamic management, they would give us the opportunity to treat the root cause of hypertension and to use a specific treatment and to treat hypertension causally.
So it's a version of what a skilled practitioner learns over time. I'd actually give the ephedrine here, not the phenylephrine. I'd give the atropine, not the phenylephrine. I'd give some fluid and that's it, Mike, isn't it, really?
Yeah.
Great.
Yeah, I really like this paper. I've already used it twice in giving talks, because it really shows that the physiology is dynamic and changing. And if you don't know what the cause of the hypotension is, you don't know how to treat it. So it was fantastic work.
So Mike, vasopressors, I've been a bit negative about the rash of the use of phenylephrine. You know, it used to be a badge of shame when we were trained as young doctors in the UK to give a vasoactive agent. It's now become essential component of giving an anaesthetic some places.
Yeah, that's right. I mean,
but it's a pure alpha. We was told don't give pure alpha, is what we were told.
Yeah, I mean, it was levo fed, leave them dead, wasn't it?
Yeah.
I mean, that's how we were taught when I was in training. But of course, now we know that norepinephrine has other, beta effects as well.
And this is norepinephrine as opposed to phenylephrine. So
Yes, that's
phenylephrine
right.
pure alpha, norepinephrine alpha and beta.
And beta, yeah, that's right. So one of the things as practice has changed in the last 10 years, and we're going to more ASA 3-4 patients, is because I use flow monitoring all the time in the OR, I realised that phenylephrine was causing problems because it would reduce forward flow. You'd correct the blood pressure, but you reduce your forward flow. So we started using more norepinephrine. And this led to me thinking, well, the trouble is a lot of hospital policies are you've got to put central lines in to put norepinephrine into a patient. So I did some work on looking at peripheral norepinephrine just in the OR or immediate post-operative space, giving it peripherally, and was there any harm there? Because if you think of it, we give codepi, don't we, through an IV, and people's arms don't drop off. And we give IM epinephrine for anaphylaxis, and your muscle doesn't necrose. And yet the pharmacist was saying you can't use dilate norepi unless it's down a central line. So we did this paper which came out in ANA a couple of years ago. And one of the studies, Pancaro's study, was at almost 15,000 patients. And you can see that even though there were a few extravasation reports, there were absolutely no tissue injuries. So we actually made recommendations that we should be moving towards peripheral norepinephrine if needed in ASA 3-4 patients, as long as you use a long 18-20 gauge in the ACF. And obviously at the end of surgery, you've got to assess whether you need to transfer to a central line depending on the norepinephrine requirements.
And in some countries and in some places, norepinephrine's been normal for a long time.
I just wanted to say I love this study because it justifies what we have done for the last 15 years without seeing any complications. So we use norepinephrine routinely with the peripheral line, and it perfectly works.
So it's a good additional thing. Mike, I'm managing time badly because we've added in the APSF recommendations. So very briefly for these results, because I do want us to go through those recommendations.
Yeah, so basically, if you fix fill, flow, then pressure, so you've got to have flow monitoring, you can make a big impact. So I knew we were going to have the impact, and this is how we got a win down in VCU, both with AKI and SSI. SSI just dissolved away. We were third best in Vizient.
So surgical site infection.
Surgical site infection, because you're perfusing the gut, don't get the secondary sepsis. We used an established ERAS protocol, so it was running for several years, very good surgery, same surgeons. And then all we did was introduce goal-directed hemodynamic therapy on 2-point optimization, which I'll show you in the next slide. And we halved AKI, which was very impressive. And everyone thinks goal-directed hemodynamic therapy can be very complicated, but the next slide I'll show you that what we did was, if you think of most of the physiological impact after induction of anaesthesia is due to positive pressure ventilation and vasodilation. So we would tip the head of the operating table down or do passive leg raise, but normally it was just head down, and see if the stroke volume went up. And we kept challenging the patient until there was no increase in stroke volume. So then we knew that we'd fix that patient's stroke volume. And it doesn't want to matter what the number is. It could be in bananas, it could be 33 bananas, but if it's 33 bananas and that's that patient's optimal stroke volume, that's what we kept the target through the operation. And team anaesthesia, all the CRNAs and everything, and the residents were really good at keeping everything normal through the surgery. And then at the end of surgery, we just re-optimized to make sure we got back to and gave more fluid. And it was just single 2-point optimization that we had that huge impact in AKI.
Beautiful.
Simple.
The consensus recommendations, Mike.
Yeah, so the consensus
a few minutes, take us through the headlines.
So it was run through the Anaesthesia Patient Safety Foundation. We had a closed conference. We invited a group of experts that you will recognize when you see the authorship. It's a who's who of published in the literature, both in the US and Europe. And we also had many stakeholders, anesthesia partners, VA, CMS, Blue Cross Blue Shield. We had all the other safety groups, IHI there. And the idea was not to give you basically clinical guidelines, but to work out how we would fix this globally from a perspective of health system and bedside provider. So we came out with current knowledge statements and recommendations, preventing hemodynamic instability-related harm during all phases of care, which we'll go through shortly, using data to drive the quality improvement process, because if you're not measuring what you're doing, you can't really map your improvement. Informing patients as well, that's been interesting, because in Europe and the rest of the world, you normally inform patients if they've had some sort of harmful event. And then we engaged also all the technology people and providers and industry, because we feel that we need to engage them to tell them what we need, like continuous non-invasive blood pressure monitoring, for instance. And finally, we want to advance the science and launch a national campaign. So we hope you will join us with all of that. And there's a whole sort of step-by-step movement that we're doing. We're going to focus in the operating room first, then go to the post-operative period. We've also got to join the team with team surgery as well, and work with the American College of Surgeons and NS Group. But really, the summary is the cause of hemodynamic instability is complex and multifactorial. We've just gone through that. But the treatment is simple, and yet, even 2 weeks ago, I was in the OR, I had all the infusions and fluids I needed, and yet I still had a patient go hypotensive after induction of anaesthesia. So it shows that it's a complex subject, and even with all the tools, we can still get it wrong. And so we looked at the 4 phases of care, and we thought that handoffs is important, and risk scoring is important. In the operating room, what's interesting, the two things we really want to do is give a rapid fluid bolus, and yet our pumps are set at 999, which means 250 mils over 15 minutes, which isn't a rapid fluid bolus. To look at fluid responsive, I give 150 mils over 5 minutes through a syringe technique. There's very low availability of peripheral norepinephrine. I was in Minnesota at the Association of Anesthesiologists just 2 weeks ago, and only 20% of people in the audience can give peripheral norepi in the operating room. So that's a problem that we all need to overcome. And then the other question is, how do we extend the monitoring and the vasopressors? Because you know, it's like the PACU nurse is always trying to get the blood pressure up so they can basically send them to the floor. And unfortunately, I think we're sending patients inappropriately to the floor who then become hypotensive. And then can we use technology to get the monitoring to the patients so that we're not having to take them to ICU, which is an expensive resource? So all this is written in the paper, which, as I say, will be online very shortly, any day now. And hopefully you can have a read at that and see what your thoughts are. Give us feedback.
Thanks, Mike. Great work. Now, relatively short on time. Long history of literature suggesting that proactive management of hemodynamics can produce an improvement in outcomes. So just two examples here. The RELIEF trial from Paul Miles, published in the New England Journal of Medicine. The grey bars, as you look at them, show the difference between restrictive, i.e. zero balance in the context of enhanced recovery, compared to being moderately liberal. And by just being moderately liberal, ignoring any particular monitoring, the AKI rate goes down by half. It's already quite a low rate of AKI, but it's gone down by half. The red bars show the FEDORA trial, which is a Spanish multi-center trial using an approach with advanced hemodynamic monitoring that addresses fill, flow, and pressure. And that takes the AKI rate down to just over 1%. So a big difference between the two.
Yeah.
In the interest of time, we'll push through for the last few slides. The Edwards Life Sciences has worked very, very hard to pull together their technology into new platforms that will not only allow the ability to predict hypotension, but give the underlying cause as a core component of it. So detect that there is instability, detect what is the driver of that instability, and give guidance on treatment. Now, Bernd, you've been involved in a relatively recent publication of testing this that's been published in the BJA Open. Very briefly summarize that for us.
Very briefly, it's a registry study, 700 patients, prospectively collected data, and this study was performed in centers who had experience with predictive monitoring. All of the patients had predictive monitoring, and the result was that the incidence and amount of hypotension was very, very low. Of course, because it's a registry study, it cannot show that the use of the predictive monitoring was the cause of hypotension reduction, but it clearly shows that predictive monitoring can help clinicians reduce the amount of hypotension.
So in the graph on the right, the red EU Hypertect 0.03 is this new variable that's discussed, which is the time-weighted average, so a summation of the amount, duration of blood pressure. And below that are the graphs of previous studies which show that there was a lot more hypotension. So we're pretty sure you can eliminate hypotension, or almost completely eliminate hypotension. Is that correct?
If you try hard enough, you can avoid hypotension.
Yeah. The question then, does it make a difference to outcome? Well, we're starting to see some publications. This is one just come out in the JTCVS, the Journal of Thoracic Cardiovascular Surgery. It's a before and after endeavor by 3 cardiac surgical groups in the USA, looking at their patients in established ERAS pathways. The infographic is from the paper. It's not an infographic from Edwards. Senior author, or the first author, Reddy et al. 795 patients at baseline, 609 using HPI with ERAS, showing a statistically significant reduction in total time on a ventilator, reduction in ICU length of stay, and reduction in stage 3 acute kidney injury, which aren't statistically significant, but as I understand it, the journal editors left them in because they're very compelling to say we should look harder at this. The right-hand side, you see the box and whisker plots, And one of the striking things for those of us who work in intensive care is the outliers. In other words, the 10% of patients who are staying for a week or more looks as though it's dramatically reduced, and indeed it is dramatically reduced. So Mike, would you summarise for us? We don't have much time for questions, but we have a little bit.
Yeah, I mean, I think we're all in agreement that hypotension is common, it's harmful, but I think the good news is it can be reduced, but it's much better to be proactive and know what you're dealing and treating than be reactive, because the pathophysiology is multifactorial. Treatment of hemodynamic instability should be addressed causally. So, but I hope that the takeaway message is fill flow pressure. It's optimized filling and stroke volume and cardiac index, and then also increase the MAP. And we've also demonstrated, I think, that there's several studies now where this HPI software can help you prevent or treat the underlying cause of hypotension and hemodynamic instability. So it means that you can be proactive and keep the patient in that sweet spot. And I think for ASA 3-4 patients, this is absolutely vital these days when you're looking at the downstream outcomes at 1 year of AKI and other complications. Thank you.
And we're going to be hearing a lot more about hemodynamic instability and a lot more about endotypes. Is that right? New thing to talk about, new exam questions.
Absolutely.
Yeah, very good.